Hello, everyone, and welcome. My name is Teresa Rickard. I help lead our practice growth and marketing here at Jones & Roth. And I want to welcome all of the practice owners and administrators who have joined us today for our healthcare webinar. I want to quickly give a quick intro to Jones & Roth, just for those of you who might be new today. We're one of the largest CPA firms headquartered in Oregon, and we serve individuals and organizations across the Pacific Northwest from our 3 offices in Eugene, Bend, and Hillsborough. Our healthcare team partners with practice owners and administrators to offer a proactive success plan, which is an approach that provides year-long value to you, maximizing operational and financial performance. We also support the personal success of practice owners through an integrated tax retirement financial management plan. We could not do these webinars without generous support, so I want to thank our sponsor, Watkinson Laird Rubenstein, for their support. They provide a broad range of legal services to healthcare practices with expert knowledge of the complex regulatory environment. Their healthcare attorneys can help you navigate through the challenges of operating a healthcare practice. Well, today I'm really pleased to welcome our guest presenter, Elizabeth Woodcock. She is a speaker, author, and consultant who specializes in helping physician practices achieve and sustain patient satisfaction, practice efficiency, and profitability. She's nationally recognized for her outstanding presentations aimed at improving the business of medicine. And she's also the author of 17 best-selling practice management books. Her extensive education and expertise, combined with her humor and engaging delivery, make her a highly sought-after speaker. We have had her many times here with us at Jones & Roth, and she is a favorite. So we have a practice management expert with us today, and we're incredibly privileged to have you with us. Elizabeth, thank you for joining us. Oh, hang on a second. There we go. Let's make sure you're unmuted. Try again. There we go.
Absolutely. Teresa, thank you so much. I really
Yes.
appreciate the opportunity to be here today. And most of all, thanks to all of y'all for joining me. It's really interesting. It's late in the afternoon on the East Coast. And I just wanted to say hi. I hate for you guys to look at my surroundings the whole time, but wanted to say hi. And just at lunch today was with a wonderful practice administrator and 2 business owners, physicians and APPs of this large practice, and just talking about how challenging it is today, reading the headlines of, CVS acquiring a large provider network. We have Dollar General, who's really doing a lot of work here in the Southeast in healthcare. And really, at the end of the day, time is your greatest asset, and that is very difficult to manage as a business. So I want to validate the challenges that we have today. And unfortunately, you won't hear a lot of good news in the next hour, but you will be more knowledgeable. All right, I'll go ahead and shut my webcam off, and we'll focus on the slides. We're going to be talking about the reimbursement landscape. And my hope is that we really lean into the coming year. But what that means is reflecting a little bit on the past and predicting a little bit about the future. But again, our runway is primarily looking at these next 11 months left of 2023. We'll start with telemedicine, just because we've heard a lot about it in the news in terms of regulatory issues in the last few weeks. Then we'll dive into Medicare reimbursement. Still a lot of confusion as to what happened with regard to the 2023 rates. We'll clear that confusion up. And not great news on the back end, but again, at least we'll have the knowledge. Then that pesky little sequestration, the 2% cuts that are still here today and will be with us for quite a while. We'll talk a little bit about the No Surprises Act, but I really want to kind of alert you as to what will be happening in the next couple of quarters. And then the quality payment program for those of you who are with practices that do have have to participate in the QPP. Let's look at what is important for the next couple of months. Then an overview of CPT, and I mentioned CVS, Dollar General, what we're continuing to see with regard to the new competitive landscape. Just a little bit about how that's going to affect us, and then we'll wrap it up with a brief conclusion. Very importantly, you'll see on the bottom of these slides with that go to arrow, there'll be a link to or a website. And of course, as you can see in the go to webinar file function, they're on typically on the right hand of your screen, you can go ahead and download those handouts. So just click through those links. What I really wanted to do was get you to the horse's mouth, because we're going to be going fast, fast, fast through all this material, partially because maybe right here you're like, telemedicine, it doesn't matter, I don't do it, I don't want to do it. So just hang with me for 3, 4, 5 minutes and we'll be moving on to the next one. For those of you who this is really important, I wanted to give you those additional resources so you could lean into those. So the last couple of weeks have really been kind of big for our telemedicine, and that is because we have the public health emergency ending. Now, just by its very term, you might say, well, I mean, of course we have a public health emergency, but like, who cares? And it's important to recognize that in the late 1980s, as part of the Budget Balanced Act of 1987, the law that was passed into, or the law that was passed, the act that was passed into law in the United States allowed reimbursement for telemedicine services on an incredibly limited basis. And that included the patient had to be in a facility, certainly couldn't be in his, her, or their home, had to be in a facility like a critical access hospital or a hospital or an ambulance, but had to be in a facility. And I apologize, not even ambulance, in a facility at that time. The facility had to be in a healthcare professional shortage area, fondly known as a HIPSA. And that wasn't all the rules, but what it meant is that less than actually 0.01% of Medicare claims were reimbursed as telemedicine services, because honestly, it was just impossible to do. And so at the very start of the pandemic, what the public health emergency allowed the government to do is to basically put a big fat pause button on all of those rules associated with telemedicine. Now, I'm not suggesting that it didn't do other things. I'm just narrowly looking at telemedicine and the PHE. So kind of think about the public health emergency as almost a, like a fire drill, where how could you get everybody out of their desk? Well, the way you get everybody out of their desk is you do a fire drill and then they leave. Same thing with the public health emergency. It gave the government the ability to, in essence, put the law on hold. And what's really been interesting is that we've seen in the last couple of weeks is that January 11th was the time that the public health emergency was written for. It will go up in 3 months, so January, February, March. And then indeed, what we do know is that the government has officially announced that the public health emergency will end on May 11th, 2023. Again, that's May 11th, 2023. So that pause, that hold about all those telemedicine rules will be gone as of May 11th, 2023. Now, in the interim, over the last, really, as we know, a little bit more than 3 years with the pandemic, is the government has slowly but surely put together a suite of services. And of course, in the medical practice environment, we typically refer to our services by their codes, which are CPT codes. I've just given you a screenshot here. But what you can see is that instead of tying everything to this public health emergency so that on May 11th, we couldn't bill for anything, the government has slowly but surely, through the regulatory process, added CPT codes to this in essence, again, this kind of pause document. In fact, there are 262 CPT codes that are allowed to be billed and paid via telemedicine, as you can see, through the end of December 2023. There's a couple, as you can see, that are, or a few, I don't want to say it's a couple, it's more than two, expires with the public health emergency plus 151 days, etc. So if you are doing cardiac rehab, physical therapy, E&M codes, if you're basically doing anything with telemedicine, I definitely would encourage you to query this list and get a sense of when those telemedicine coverages end. Now, hold the phone just a little bit, because when I said telemedicine services end, there's a little bit of an update. I'll just ask you to wait a second. But let's go back in time just a little before we do, because I think it helps inform us of where today is. Soon after the public health emergency started, we all know that telemedicine became the vital tool for us to deliver medicine to services to our patients. Our patients weren't allowed to drive into the office. We didn't want them to drive into the office to be exposed to them. Sometimes, like here in Georgia, where I'm from, we had state laws that said you need to stay in your houses. You can only go out for X, Y, and Z. So we, of course, got into quite a pickle, and telemedicine was our vehicle to be able to deliver services, at least on an outpatient basis, of course. Now, oh my gosh, as you can imagine, Americans started to really kind of like the convenience of telemedicine. In fact, one of the big things that I do a lot of work on is appointment no-shows. Appointment no-shows. As we started off at the beginning of the presentation, your services, your time is your most valuable asset, but it's finite. You can't store it up. So if a patient doesn't arrive for their appointment, basically it's wasted time where you get paid nothing, nada, and you can't then go and pivot and give that time to another patient in your community. So it's a real travesty when we have a non-arrived patient. So one of the things that I'm seeing practices do quite successfully is when they are calling to do appointment confirmations and the patient says, particularly in the very tight runway, like, the day before, 2 days before, when you can't refill that slot, and the patient says, sorry, cannot make the appointment tomorrow morning, my apologies. And before you'd be like, well, it's been 24 hours, I'm not really going to charge them. I mean, okay, Miss Woodcock, when do you want to reschedule for? And so what we're seeing practices do is, oh, Miss Woodcock, completely understand if we were available to offer telemedicine encounter, because of course that would mean you wouldn't have to worry about transportation, you wouldn't have to worry about the inconvenience of coming to our office and the time associated with it. Is that something you would actually stick with your visit? And what is remarkable, I swear to y'all, is that I am seeing practices report 50%, 50% of those patients who are saying, yes, we will take the appointment. Now, I'm the first one to say, like, of course it has to be medically appropriate, but patients love the convenience. So really interesting strategy. And of course, the federal government is feeling this too and saying, what's going to be happening with telemedicine? So they started studying it quite soon after the public health emergency started, as you can see from the Medicare Payment Advisory Commission, which is the advisor to the federal government. And if you scanned this yellow, they're saying, ooh, yeah, we like it, but be careful. Be careful. And again, more information coming out, this report just 6 months ago. Yep, we like, telemedicine. It makes sense. Let's study it. Let's figure it out. But, ooh, we got to be careful. It's great access to care. It promotes equity because of the transportation, the child care issues, et cetera. If I can service a patient in their home, wow, isn't that better? I mean, nobody has to pay for gas, for example. So it's a really nice service from an equity lens perspective. It's cost effective, it's safe and efficient, but there are some challenges to it as well. So everyone is acknowledging the pros and the cons. But at the end of the day, the federal government says, well, we are going to go ahead and make these services available, and we're going to do this before the public health emergency ends. So as you can see, just a few days before 2023 began, the Consolidated Appropriations Act really was kind of the pressure cooker for a lot of different things, and solidified that waiver, that pause button that had been put in play by the public health emergency for telemedicine services. And so through the end of 2024, so we now have a 23-month runway. Patients can be serviced at home. Patients can be serviced via audio only services, which is a big, big thing for Medicare patients that still have a hard time figuring out how telemedicine, like getting onto the portal, getting onto the telemedicine platform, etc. So you can still have phone call only services covered by Medicare, and that does include our office-based E&M codes. There are also some guidelines for mental health as well as community health centers like rural health clinics and FQHCs. So 23-month runway. Here is the information. It's a very long, thousands of page bill. So I went ahead and gave you the actual page number that you want to start at if you are performing telemedicine, or even if you're not, but want to consider doing so. Now, there's still a lot of question marks about telemedicine. For example, we were talking last week about the issue of controlled substances, being able to prescribe via telemedicine. We still haven't had the final word from the DEA about that. And of course, as we well know, the states are also involved. So many of you, of course, being from Oregon and Washington, not only do we have to understand what's going on at the federal level, but because the state controls the scope of practice, the state controls the fact that Oregon physicians are indeed providing services in Oregon, and they're the ones who are making any exceptions to that, that we have to look at every single state to determine what the extent of telemedicine offerings can and will be. The best kind of way I keep a pulse on that, especially if you're near the state border, Oregon, Washington, for example, or maybe California, is that indeed you want to take a look at this Federation of State Medical Boards. This is it actually is updates almost every week about what is going on at the state level. It is excellent. So enough about telemedicine. Lots of news from a regulatory perspective. Wanted to make sure I went over those. Now let's move on to Medicare reimbursement. Really, really bad news that we got in the fall. There were some projections of even more extensive cuts, but basically right about October 31st, I always love, it's kind of like the trick or treat because it comes in on November 1st or November 2nd, the announcement about the coming year's reimbursement rates. And as you can see, all this, conversion factor, fancy language, basically Medicare was set to go down by 4.48%. And you might ask, why? Are you kidding me, Elizabeth? You're telling me that physicians are going to get 4.5% less in 2023? They have literally upheld the healthcare system in the United States. Not only that, but there are stories over and over again about everyone retiring, all providers burning out. Believe you me, my husband is a physician. It is a really, really tough profession. 4.5%? Are you kidding me? And the government said, well, listen, here's how we got here. The 2022 conversion factor, which is basically kind of an index, if you will, in terms of how they pay reimbursement. Well, what we were supposed to have done was a $33.59 conversion factor. I say supposed to because we passed a law last year called the Protecting Medicare and American Farmers from Sequester Cuts Act that stopped the cuts from 2022, but all it did in essence was kick the can down the road. So here we are in 2023 and y'all are mad at us, but honestly, 2022 shouldn't have been a high as it is today. So in essence, we got to kind of make up what we did last year in 2023. So I get it. Now, in addition to the conversion factor, each individual specialty is a little bit impacted by changes to the actual relative value units that are associated with the CPT codes that they use. I almost hesitate putting diagnostic testing facility up here because there are so few services that are run through the professional fee schedule. But for those that are, and I'm talking about tiny, 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 they are seeing an uptick of 7%. ID and internal medicine, 4 and 3% respectively. And another year where IR and vascular surgery, which share a set of codes because they often perform the same services for a certain part of their business, and you can see they have a 3% decline. Now, if you're in another specialty, I guess good news, because you will have between -2 and +2% change according to Medicare's resource-based relative value scale. And again, what's really interesting is if you scan this list, and here's the rest of them, and I've given you right there, there's the source, you can go right into the Federal Register. But when you add all of these up, they basically neutral out. So what happens with the professional fee services each year is some CPT codes get a little bit more units and some get a little bit less. But at the end of the day, the federal government has to have in that total row 0%. So if you got more, somebody else got less, and vice versa, and vice versa. Now, I do want to mention, and I apologize that I'm even having to say this, but professional services, the resource-based relative value scale, which is the scale that defines professional services, are for physicians, advanced practice providers, anyone who's billing under as a professional fee service. Facilities like hospitals, nursing homes, skilled nursing facilities, etc., they actually are on a completely separate reimbursement schedule. For, well, I hate to even say this out loud, but their schedule is based on a market basket index. And so what that means is, in economics language, is that when the economy doesn't do as well, then they basically get made up for it on the fee schedule. So in essence, they actually get more money. In fact, they've gotten more money for the last 10 years. They've seen increases between 0.5% and 2.5%, while professional fee services have gone down, 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 down every single year. And this is another good example. If you're a professional service that is actually performing a service in a hospital, so these are all of our hospital-based clinics, or sometimes we call them provider-based clinics, you're actually seeing an increase. Like, look at infectious disease. If you are an ID physician who is practicing at a hospital-based clinic, you're seeing a 6% increase, while if you're a private ID physician seeing patients in a private outpatient facility or private outpatient clinic, which is billing as a place of service 11, your reimbursement is going down by 2%. So unfortunately, the sort of the favor really swung towards hospitals in 2023. So I mentioned the 4.48%. You might be now looking at your remittances and maybe you don't even look at them, but you're like, we're not getting a 4.5% decrease. We're just getting a decrease, but it's not that much. And the reason is that the Consolidated Appropriations Act, the same law that gave us that extension for telemedicine on December 29th, also took that 4.48% and said, we're scrapping that. Instead, we're going to decrease the reimbursement scale by 2.5%. Now, you don't see the word decrease, but unfortunately, the federal government uses the term adjustments every time. They actually are looking at an adjustment downward, 2.5%. I mean, I guess it's better than 4.48%. It's still a little bit frustrating. And as you can see, they've already put into law 1.25% for the next 2 years. Again, better than 4.48%. That is for sure, but certainly wish that had been a plus in front of it. Now, if you're interested in figuring out like all of this theoretical stuff, like how does this impact my practice? What I would recommend doing is going to this handy dandy and free physician fee schedule lookup tool. You can go right to this, and it allows you to give the rate for any CPT code for your location. So for example, if you have a clinic in Vancouver, Washington, and another one in Portland, then you're actually going to see two different Medicare payment rates. And you can look all those up. It's super easy. It's a great tool. I use it all the time. So the final 2023 conversion factor is $33.88. It is, as you note, not quite as bad as it could have been with a 4.48% by law. Another law came into play on December 29th, and with just literally a few business hours left in the year, stopped that 4.48% and made it finally be 2.5% decrease. Now, there are some opportunities, in my opinion. In fact, I was reading a great article that was in the American College of Physicians from last summer that looked at lost opportunities for primary care physicians and estimated that primary care physicians were leaving $200,000 each on the table. And you might say, whoa, where do they come up with that data? Well, the way they came up with that data is they looked at the Medicare claims database, and they were looking through all of the Medicare patients and seeing which ones did not have preventive services that were covered in full, right? There's no cost share for these services. They were covered in full, and the patient was eligible for them, but they weren't provided. Now, you could argue, well, okay, but we were busy and, we couldn't accommodate the patients. But these researchers said, there is money being left on the table for services that you could have been billing. So you can take that for what it's worth. But please know that this is a great tool for you or your team to take a look at. And you click on each one of these tiles and it opens up all of the Medicare preventive services and what is the coverage limitations. As you can see from the little T, which ones can be done by telemedicine. And that does include, look at this. We've got diabetes, self-management training, annual wellness visits. And I love annual wellness visits is a great example. You can have your nurse do those. There are some really great opportunities. A lot of these screenings and counseling can really be able to leverage our providers' time. That's a great quick tool for you to use. So that pesky little sequestration, that's that 2%, the 2% that is taken from the payments that Medicare makes, to physicians and advanced practice providers. And I say that because it's not applied to the allowable, it is applied to the actual payments itself. And so we can see that we have sequestration through not just 2025 when it was supposed to actually have started, but it was through 2030, as of now. So the reason why this happened is because 2022, we saw the government say, oh, you don't have to worry about sequestration for that first quarter, January 1st through March 30th. For the second quarter, We didn't have 2% taken off. We had 1% taken off, but then it kind of all started back as of July 1st. But because we were exempt from it for a little while, that's why it got extended until 2030. So if you take a look at your Medicare remittances, you will see the SARC code, which is Claim Adjustment Reason Code. It is CO, Contractual Obligation 253. The CO means you are contractually obligated to accept it, that reduction in federal payment. Now, I mentioned briefly in my opening remarks about No Surprises Act. As you well know, this was effective last year as of January 1st, 2022. And I think it's more broad reaching than many practice administrators and business owners had recognized. Because at first, I know for me, I thought, oh, well, it's just for people who don't see patients who only see patients out of network. But really, it's much more broad than that. But the message that I want to give you now is not only if you have no idea what I'm talking about, or you don't have any language that patients are reviewing when they come into your practice about No Surprises Act, just a kind of quick tip to make sure you look up more about this and make sure you're in compliance. But the big news in 2022 and rolling into 2023 is that the government was not prepared for how many disputes would come through their doors. And uh, I mean, they just weren't prepared for it. So this independent dispute resolution, there were bodies, third-party vendors that were allowed to bid to be IDRs. There just weren't enough of them, and they didn't do it fast enough. And so, unfortunately, the government and these IDRs are fairly behind. And so I think as we start seeing those backlogs work down, in the next couple of months, let's kind of be on the lookout for news about the No Surprises Act as the government kind of recalibrates the system. Very importantly, for those of you who do have to participate in the quality payment program, and let me step back when I say have to participate. This is a program that is completely voluntary. But if you do qualify and you decide not to participate, you will be penalized. And so I'm not really sure we can say it's quote unquote voluntary. So it's really important for physicians who do have to participate, and probably if you do, if you are a physician or an advanced practice provider, you can go right onto the Quality Payment Program's website. All you have to do is key in your NPI, your National Provider Identifier number, and it will tell you if you are qualified to participate in the program. If you are eligible, then I would highly recommend participating, because otherwise you will indeed be penalized by 9%. That's a massive amount of reimbursement decrease, particularly on top of the 2.5% we just talked about. That's a lot, 11.5%. You cannot afford that. So you have to pay attention to performance year 2022, like what you did last year. And the reason you do is because you are reporting on that right now. The portal went open, I think it was January 3rd. And so you're reporting on that right now, but you're also having to perform 2023. Now, a little bit of a look back, and I know this is a little frustrating to see, like, okay, Elizabeth, it's 2023. Why are you showing us a slide about 2020? But the government is about 2.5 years behind in terms of reporting for previous years. We should actually see the 2021 reporting year out any day now. But what this demonstrates to us is the fact that if you in 2020 were an exceptional performer, like you did the best of the best of the best, you got a 90% plus score, like you were awesome, or 85% plus score, excuse me, which 81% of physicians got, you for your maximum adjustment got 1.87% as your bonus. Woohoo! I don't know about y'all, but that's like to get, I mean, I scored 100%. This program is hard, y'all. And that's what I'm getting, 1.87%. And in fact, when you look back at what the quote unquote perfect scores get, it's ranged between 1.7 and 1.9% for the entire part of the program. But I think the biggest message I need to send here is that 2022 is the last year to even get that, And the reason behind that is the government gave 5 years to itself, to the program, to the Centers for Medicare and Medicaid Services, which administers the program. It gave them 5 years to be able to have this exceptional performance bonus. In essence, it was kind of like a pot of money they created. That is ending after 2022. So when you are looking at what you are doing right now in 2023, I want you to ask yourself, like, what's the business case here? To get 100, what am I needing to do? If I need to hire a nurse to do this, if I need to hire a 0.5 nurse to do this, I'm just asking you to go back and make sure that you look at your return to figure out, is my return on investment, how much does trying to get that perfect score cost me? Now, it's important to recognize we have to avoid the 9% penalty. So I want to make absolutely sure that you meet the minimum threshold. My question is, do I really need to get 100? I know you're competitive. I happen to be married to a uber competitive physician too, but I'm like, he's actually in charge of his MIPS program for his practice. And I'm like, woo, let's take it down a notch, because you're paying way too many people to do this program for you. And 2022 is the last reporting period that you will have where you can even get the 1.87, 1.9, 1.76. It changes every year, but it's been between 1.5 and 1.9 for the last 5 years. So I don't expect that to change. And even that, again, is going away. So a little program hack. I love hacks, and this one is truly one. For the quality payment program, there is an extreme and uncontrollable circumstances exception. And I don't know about y'all, but who hasn't been in the midst of an extreme and uncontrollable circumstance? Please, I think a lot of people have. So what this is allowing us to do is it's an application, and the deadline was recently extended to March 3rd. So we've got, what is that? Another 3 weeks for COVID related disruptions. I don't have to have any sort of proof. I don't have to have, like, that this disruption has caused me, to not be able to report, to not be able to da 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 da. It is a COVID related disruption, but you do have to apply. What was interesting is in 2021, the government automatically exempted all providers from the quality payment program penalties because of COVID. But now you do have to apply. So that extension was to March 3rd. And let me just make sure that I state specifically, because we've been talking about different years, this exemption is for the 2022 reporting period. So if you look back at the last year and you're like, heck, Elizabeth, I definitely did not report this effectively, I don't even know what you're talking about, then you need to get yourself down to this exception application and fill it in. Doesn't take that long, and it will make sure you do not get penalized at 9%. Who needs a 9% penalty? Nobody. So I very briefly mentioned this threshold. I want to make sure in 2023 y'all avoid that penalty. Now we can keep our fingers crossed that the government will give another exception application, but I don't like to keep my fingers crossed for a 9% penalty about anything. So 75 points, you got to get there. You don't need to get to 100, but please, goodness gracious, get to 75. That will avoid the penalties. And you should be like in week number, what is it, 5 for the quality payment program for 2023. Please note that there are changes. There are changes to 76 quality measures, as you can see on the bottom right-hand corner here. And very importantly, I just point out, because a lot of physicians use this, the flu and pneumococcal vaccine quality measure, that actually was deleted. So nobody from the government is going to call you and say, are y'all still using that? Maybe maybe you shouldn't. You've got to monitor this yourself. So for CPT 2023, really the big change that we had was the observation services were merged with inpatient codes. If you don't go to the hospital, see patients, 2023 is kind of a blah year for you for CPT. If you do go to the hospital to see patients, especially if you see them outside of the OR, like a non-surgical, if a medical physician or in a medical, like a consult service, etc., big changes, big changes. In essence, what happened was the changes that went down in 2022 with office-based codes got replicated to the hospital with inpatient codes. And so this is kind of basically is a good table for you. But I got to tell y'all, if you are a rheumatologist, a neurologist, a physiatrist, anyone who's going into the hospital a lot for consultations, please make sure that you are looking at the American Medical Association's website about these E&M changes. And the reason I say that is the American Medical Association is the truth, the source of truth for CPT codes, because they are the authors of the CPT manual. So I really love some of the materials that they put out in the last month or so. So definitely would encourage you to look at that. So we're seeing, I mean, every day it's amazing the news that is coming out in terms of the competitive landscape. This morning it was CVS and Oak Street. Basically, all of these companies are the ones on the right, which of course are the more, the Wall Street publicly traded companies, and the ones on the left side of your screen, those are early stage private companies, but many of them, of course, not profitable. I don't know how you are profitable in the outpatient space, but they are providing value to these publicly traded companies, and so they're getting snapped up every single day. And of course, what this is doing is creating an incredibly interesting landscape. I mean, I'll just take, for example, Cigna bought MD Live recently. And Cigna is a health insurance company. MD Live is a telemedicine company. And you could say, well, like, who cares, right? It doesn't really matter to me. You do you. The challenge is that these insurance companies are now providers themselves. And in fact, we're seeing pay riders is kind of the new term, because it's payers and providers, that terminology, those two terms merged into one, because these companies are launching virtual first health insurance, for example, which basically means if I'm part of one of the health plans, then I log on to Cigna's platform first. I don't even go to see a doctor. I log on to Cigna's platform. I get a consultation from a physician via MD Live, and then the MD Live physician is the one who sends me onward. So these virtual first health plans are just pouring into the market. And again, what that means is they see a doctor first on telemedicine, and sure enough, they even own the platform. And then, of course, we have the merger between United Healthcare and Change Healthcare. Massive, massive, big change. United Healthcare is obviously one of the nation's largest, if not the nation's largest health insurance company. Change Healthcare is the nation's largest clearinghouse. Now, what a clearinghouse means is it's think of it as like the information highway for claims. So when you, for example, you see a patient and then you send all that information into your EHR system, and then you pay somebody, or you have, maybe her name is Sally. Sally is down in the billing office and Sally's keying all this and sending off a claim. Like, you send out 35, 37 elements, data points about that service, the patient's diagnosis, the data service, et cetera, and it moves into a claim and it goes on to this information highway, a claims information highway that United Healthcare now owns. Absolutely. I mean, talk about game changer. And of course, most of this competitive landscape has been really, really centered on the urban markets. But what we're starting to see is more and more movement into the healthcare deserts. And that is being led by these companies that really specialize in quote unquote urban and rural markets. We certainly have a lot here in Georgia. I know y'all do as well. But what we're seeing here, of course, is companies like Dollar General. Best Buy is another really interesting play. Best Buy actually bought a nurse line, like a call center. Actually, I think it was 5 years ago. And then they bought a lot of remote patient monitoring companies. They also bought a telemedicine company. So next time you see the Geek Squad, who are coming out to fix the computer at your house, they're going to be coming out to install the, PFT for the patient, whatever other monitoring device you order. And then it won't be you who is doing the remote patient monitoring. It'll be a Best Buy Health doctor. So huge, huge changes, huge shifts. And I like to think of this as like, you know, I'm a taxi company in 1990, 1995, and I'm like living the life, y'all. I mean, I got so much demand. I'm a taxi company, and my drivers, maybe I give out medallions in my city so I can control the number of taxis, but like, I owned this space. Little did I know that somebody was in and, probably working out of their home and thinking about ride sharing and developing Uber and Lyft and all the other companies that specialize in ride share. And where am I as a taxi company today? Probably not in business anymore. And we could, of course, talk about, hotels, Hilton and Marriott, thinking about, what did Airbnb just happen? Because I mean, think about what that has done to our business. So the issue is, of course, we don't want to get blindsided. So in order to avoid getting blindsided, we got to start thinking about, like, okay, where are all these players and how can we stay competitive? And very importantly, we've talked a lot about patient service in the last few years, but it still feels, even when we use the term experience, like help me out. How can I grasp how to do that? And I'd like for you to start thinking about convenience, because once we start thinking about convenience, it starts to make a little bit more sense, and we can unpack this and say, okay, like, I get it. It's actually inconvenient to only be able to schedule an appointment between 8:30 and noon and 1:30 and 4:30 p.m. Why? Because that's when our phones are on, right? So if I want to offer more convenience to my patients, then I can start thinking about self-scheduling, right? And that's just one example, but really kind of hone in on convenience and recognize that there are going to be changes in how we get referrals. Like, is Best Buy going to send you patients? Is Cigna MD Live going to send you patients? But please make sure we recognize, we don't ignore what's happening in our industry. And I think this has been really, really difficult for us, because in the midst of all of the shifts in terms of these different companies, including the fact that when we look back at telemedicine, and the first, 5 minutes of this presentation was all about telemedicine. Well, Cigna loves that, right? CVS loves that. Dollar General loves that because now they can actually very comfortably think about telemedicine for the next 23 months, just like we can too. So I like to think about it as like we're the incumbents, we're the legacy healthcare system, the doctors, the hospitals, like the traditional healthcare system. What we have to be aware of is the new wave, right? The fact that we've got new competitors who are bringing in different services or different delivery than we can. So they're apt to benefit from that change as well. And here we are left with incredible amount of staffing shortages. And we're facing what is the reality at hand, which is the fact that when you think about what happened during the pandemic, right? I just mentioned patients couldn't come see you. I mean, we were struggling just to have our doors open for months, not just weeks. And it's not like, I mean, I shouldn't say there was some assistance by the government. I should not be so discount them so much. There certainly was some assistance for physicians from the government, but the insurance companies made out big time. And the way they made out big time is the fact that they didn't call us. We're all, or many of us, are insured. Like I know I am. I have health insurance from my husband's company. They didn't call my husband's practice and say, "Oh, I see that y'all aren't getting much health care, right? You're not going to see the doctor. You're not going to the hospital because you're all sitting at home. You're not allowed to go out of your home." They didn't call us and say, "Don't worry about sending in the premiums." They kept collecting those premiums in 2020 like candy, right? I'm just picking it up, picking it up, picking it up. And they weren't paying anything out. So now that healthcare demand has picked up big time, unfortunately, companies like United Healthcare, they actually are having to pay out a lot of claims. So what they're doing is because their stockholders are saying, whoa, 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 you cannot let that stock price fall. You got to keep it up. The easiest way to keep up that stock price is to not pay out services. And because there's services to pay out, the only way they can do it is to deny claims. And so this has been really, really frustrating for practices. It is, and I told y'all it wasn't going to be all good news, right? This is our reality, and I want us to be aware of it, that we are seeing claim denials, and it is really important, despite the fact that we don't have we have this softening of staff, is to please make sure that you get paid what you deserve to get paid. And what that means is identifying and following through on claims that are denied. I mentioned very briefly, demand is increasing. The data is playing that out, that we are seeing surges in demand. And what my hope is that after spending a number of years just being happy with a 2.5% decrease, is that it's time to turn the tables. It's time to go back to where physicians and advanced practice providers were even 10 years ago, which is you had a voice at the negotiating table. You had a voice. And I'm starting to see that now as supply and demand falls out of balance again, where we simply do not have enough providers to take care of the demand that we're seeing for healthcare. I mean, just think basic economic principles means you're going to be in a better position. You're going to be a better position to negotiate your reimbursement. So I wanted to kind of end because I think that's a good note. I don't know. I think we're on the cusp of it. We're on the cusp of it, but it's there. So let's just briefly recap. Big changes in telemedicine. Basically, the public health emergency ends, but telemedicine coverage is extended by another law through the end of 2024. Medicare reimbursement, we didn't get whacked as hard as we anticipated, but we still had a decrease. Sequestration, that pesky little 2%, will still be around for through 2030. The No Surprises Act will see some information, I hope, to come out of that as the government and its independent dispute resolution bodies move through those claims. The Quality Payment Program has that nice COVID exception, but you do have to apply for it. Don't forget that March 3rd deadline. The CPT codes, brand new. Really, the big hitters were on that hospital inpatient observation services. And then I hope you've at least been enlightened by some of the changes in the competitive landscape that are extending not just to urban markets like Portland and Seattle, but far, far beyond those doors. So I'd love to take the opportunity now to turn it back over to Teresa, who will begin our Q&A period. Teresa?
Yes, yes, hi. I think we have time for two of the questions that were submitted. So thank you so much, Elizabeth. This first question is, on the Medicare telehealth services spreadsheet, how shall blank status columns for 90785 to 90853 be interpreted?
That's a good question, and I'm sorry that I don't have those CPT codes off the cuff. So I would need to look up what those are. But how they should be interpreted is basically the law now reverts back to that, or reverts to that Consolidated Appropriations Act of 2022, and therefore we have basically 23 months to perform those services for Medicare reimbursement. Now, that doesn't mean that all payers do have to pay them. This is an important distinction because we don't have a single payer system in the US, but I think it is good news and it gives you the runway. I think it was 90753 or 83. It gives you the opportunity to go to those other payers and say, hey, listen, Medicare is paying for this via telemedicine. Won't you? Teresa?
Okay, great. Second question, does Medicare Advantage also take the 2% payment adjustment?
Oh, it's a good question. They do, but they shouldn't. And so I say that because Medicare Advantage plans do have to pay the federal government because the federal government is paying them. They're, in essence, commercial payers that are kind of like in between doctors and hospitals and the federal government. And so the federal government is taking 2% from their payments, but unfortunately, they're passing it on to doctors. They can take whatever money they want to from you because it's a third party company and it's a third party. It'd be like, me and you getting into an agreement, but you are not legally obligated to accept it. You are legally obligated to accept the sequestration directly from Medicare, but not from Medicare Advantage. If you need some fodder for that, if you want to fight back, shoot me an email. I'll be happy to provide a lot of good information. It doesn't always work, but Medicare Advantage, again, they do, but they should not be taking that 2% from you. Teresa?
Elizabeth, thank you so much for sharing your expertise with us today. So many great takeaways, really. Before we close, I just want to mention that this presentation does offer CEUs. You can download those in the handouts area, the certificate. Thanks everyone for joining us. Have a great afternoon.